All right, starting us off with Section 1, the asymptomatic gallbladder. To cut or not to cut? Okay, so imagine this scenario popping up on your screen for question 58. You've got a 70-year-old female patient. She has a 2-centimeter gallstone. But look closely at her chart. She's got diabetes, hypertension, and ischemic heart disease. Oh, and here's the kicker. She has absolutely zero symptoms from that gallstone. Take a second and let that sink in. The test writers are deliberately throwing all these heavy, intimidating comorbidities at you, right? They want to see if you'll panic and immediately try to jump in and fix her. Well, your first instinct might be to rush her to prophylactic surgery just because of her diabetes and heart issues, but actually, scratch that. The correct answer? Do nothing. Just observe. Why? Because asymptomatic gallstones are generally not operated on. And more importantly, having diabetes all by itself is definitely not an indication for a prophylactic cholecystectomy. Basically, the risks of the surgery totally outweigh the risks of just leaving a quiet stone alone. Moving right along to Section 2, high-risk gallbladder infections, managing the unstable patient. So for questions 57 and 62, I want you to put yourself right in the middle of a busy ER. You've got an elderly, septic patient with an empyema, which in plain English is just a gallbladder completely packed with pus. Or maybe you have a diabetic patient with emphysema cholecystitis, meaning there is literally gas actively forming inside the gallbladder wall from a super severe infection. These patients, they are crashing. So how exactly do you manage someone who is this unstable and septic? Okay. Step 1 is always a percutaneous cholecystotomy. What does that actually mean? You urgently place a drain through the skin directly into the gallbladder. You absolutely have to drain that infection first because these patients are just way too septic and high risk to survive an immediate major open surgery. Then, step 2 is the interval cholecystectomy. That means you go back and do the definitive surgery to take the gallbladder out much later on, but only if the patient actually becomes fit enough to handle it. So the golden rule here is drain now, operate later. But wait, what if the infection isn't just in the gallbladder, but it's spread into the main bile ducts? Now we're talking about acute ascending cholangitis. When a patient hits Reynolds pentad, meaning they've got jaundice, a fever, right upper quadrant pain, plus septic shock and an altered mental status, they have grade 3 cholangitis. This is a massive, critical emergency. So, what should your very first move be? Here is the life-saving sequence. Step 1. Aggressive resuscitation and IV antibiotics. You've got to stabilize that blood pressure first. Step 2 is urgent ERCP decompression. Essentially, you use an endoscope to go in and unclog the plumbing. You might cut the sphincter or place a stent just to let all that infected bile drain out. And then, only after they've completely recovered, do you move to step 3, which is the definitive gallstone surgery. All right, Section 3, managing pre-op common bile duct or CBD stones. Now here's a classic known stone exam trap. Your patient is already scheduled to get their gallbladder taken out, but during routine preoperative imaging, like an MRCP, you see a 1-centimeter stone stuck right there in the common bile duct. So what's the standard sequence of procedures here? Think about it for a second. You know the stone is already there before you even make a single surgical incision. The absolute key here is tackling this in 2 very distinct stages. Step 1, you do an ERCP to retrieve that common bile duct stone first. You've got to clear the duct. Then, step 2, once that duct is totally clear, you go ahead with the laparoscopic cholecystectomy to take the gallbladder out. It's simple logic, really. Clear the pipe, then remove the source.
Next up is Section 4, intra-op and post-op stones. And here, timing is literally everything.
For question 61, I want you to imagine you're the surgeon in the OR. You're doing a routine lap chole, you decide to do an intraoperative cholangiogram, squirt some dye into the ducts to double check things, and boom, there's a stone in the common bile duct that you had absolutely no idea was there. What is your immediate next step while that patient is still asleep on the table? The answer is a single-stage management approach. You do the laparoscopic cholecystectomy plus a laparoscopic choledochotomy. And a choledochotomy just means surgically opening up that bile duct to fish the stone right out. The reason this is the preferred answer on exams is that if the surgical expertise is right there in the room, you should absolutely handle it then and there. 1 surgery, 1 recovery. Easy.
Now, question 59 shifts our timeline way forward. It's been 3 whole years since your patient had their gallbladder removed, but now they're coming in with biliary pain, and imaging shows a recurrent common bile duct stone. The gallbladder is long gone. So how do we handle this one?
The really straightforward answer here is ERCP. specifically an ERCP with a sphincterotomy and dormia basket retrieval. Because there is no gallbladder left to remove, an endoscopic approach is just perfectly suited for this kind of late post-op scenario. It is the absolute standard first-line treatment, for sure. Okay, let's look at question 60. This is honestly one of the trickiest timing traps you're going to face. You've got a patient who just had an open common bile duct exploration. The surgeon left a T-tube in place to let it drain, but just 10 days after the surgery, imaging shows there is still a residual stone left behind in the duct. Do we rush back in to extract it right away? No way. You absolutely do not rush this. On day 10, when that stone is identified, your best action is to just wait. You actually have to wait 4 to 6 weeks. Only at week 6 do you go in and perform a choledocoscopic retrieval through the two-tube tract. Why the wait? Well, the physical tract around that tube needs those 4 to 6 weeks to mature. Basically, scar tissue has to form a safe, sturdy tunnel. If you get impatient, pull the tube, and try to extract the stone too early, that delicate tunnel collapses and you get bile leaking everywhere into the abdomen. So patience is strictly mandatory here. And finally, Section 5, High-Yield Exam Traps. We're calling this the master key. All right, here is your rapid-fire summary. Binding these specific scenarios to their logical triggers is going to totally save you from exam day confusion. Are they asymptomatic even if they have diabetes? You just observe. Are they unstable or septic with an empyema? You drain it first with a percutaneous cholecystotomy. What if you know about a CBD stone pre-op? ERCP goes first. If you unexpectedly find a CBD stone intra-op, do a laparoscopic CBD exploration right then and there. And if you have a residual stone with a T-tube, remember, you've got to wait 4 to 6 weeks for that tract to mature.